So again, I wanted to mention the purposes of the It's My Life program, focusing on individuals with severe psychiatric conditions, and focusing on the most misunderstood and isolated members of our community. The It's My Life program assists peers in finding their power to reclaim their place in the community. We provide a safe place for individuals to learn and practice skills to prepare themselves as they move forward in their chosen paths of recovery. Participants in the It's My Life program are accompanied on their journey of recovery by trained peer life coaches who help them to bridge the gap to a larger social world. The definition we have of community inclusion includes the opportunity to live in the community and be valued for one's uniqueness and abilities, just like everyone else. To promote inclusion, we need pathways from segregated service provision into mainstream services, where there isn't a separation between the sick and the well. Focus on groups or activities solely for persons with mental health problems. They reinforce segregation unless they are part of a supported pathway into mainstream services that are accessed by everyone. The principles of community inclusion include rights, which is shifting from least restrictive to most inclusive. And that's similar to our shift from mental illness to mental health. The second principle of community inclusion is the roles. That's the rights and responsibilities must be viewed across a wide range of life domains. The third principle is responsibilities. Community inclusion implies that the consumers, as they're called, assumptions of varied responsibilities, that they have the different roles and responsibilities in their community to really be a part and be able to contribute. Principle 4 is about choice, responding to each individual's set of community inclusion priorities and their concerns about the pace of change. Social connection fits into the overall goal and journey of recovery. The It's My Life program is designed to help people build the networks of friends and intimate relationships, and this creates a strong social support system, which we all know is very important to recovery. It helps to increase self-esteem and self-worth, which improves overall social functioning. Ultimately, the program uses a self-directed care model to help the participants set and reach social and personal goals that might include going back to school or finding a volunteer position or competitive employment. The pilot project for the It's My Life program focuses on individuals with schizophrenia or schizoaffective disorder because they're the most, often among the most communities most isolated and marginalized. Schizophrenia, definition for schizophrenia is that it affects how a person thinks, feels, and acts. Someone with schizophrenia might experience difficulty distinguishing what's real from what's not, and they may be unresponsive or withdrawn and have a hard time expressing so-called normal emotions in social situations. And those with schizoaffective disorder may encounter similar troubles, which could be accompanied by a mood disorder. So given the complexity of the conditions of schizophrenia or schizoaffective disorder and the knowledge that social functioning impairments, they happen at all stages of the illness, sometimes even before any symptoms are noted. So the need for innovative approaches in helping them to develop social skills, friends, and intimate relationships is really quite acute for people with schizophrenia. And of course, although we piloted this program with a focus on schizophrenia and schizoaffective disorder, The principles and practices of self-directed care can be applied with any mental health diagnosis, anyone at any end or point in the recovery path. We're going to do a brief overview of the It's My Life process, especially for those who may have missed part one of our webinar. So we're going to look at life coaching first. The life coach trainers, basically, what we did here in our pilot program, our coaches went through a program with Boston University's Psychiatric Rehabilitation. And it was a master's level course that we studied for a very long time before implementing the program. We also studied motivational interviewing. We studied professional life coaching and personal outcome measures and the many other things that we incorporated into this program. And you will learn a bit more about the training that our coaches receive and the other components of the It's My Life program throughout today's webinar. Next is recruitment. That was our process of reaching out to potential participants, determining their eligibility for enrollment, and getting everyone started and what we needed to get them going. Then we have the forming of the partnership. That's the bond between the life coach and the participant, how that gets started, and how we incorporate all of our components into building that partnership. For skill building, we taught, the life coaches would teach various skills using tools such as distress tolerance, role-playing, talking about personal boundaries. And the purpose is to strengthen the participants' interaction with themselves and with others. So the participants were accompanied out into the community with their life coach. They were able to choose some goals for themselves, some social goals. They chose 3 for the month, and we gave them a stipend, $60 a month stipend to spend on social outings and building their social skills and meeting their social goals. And so their coach would go out with them into the community and help them practice those skills that they identified that they wanted to learn and wanted to implement. And once they practiced those skills with their coach, they would go out into the community, utilize the skills, and then be able to reflect back with their coach to see how things went. As things progressed, the coach would gradually draw back so that the participant would be able to go forward into the community of their choice without the support of their life coach as they continue to grow. The evaluation techniques is something else that we will also cover today. We will talk about the rehospitalization rates that we achieved, satisfaction surveys, personal outcome measures, as well as the guided journals. Those were our measurements for success with the It's My Life program. And then lastly, we will cover what our outcomes actually were. So one of our evaluation techniques was the personal outcome measures, the POMs. It starts with a person's own view of their life. Then the outcome defines what is important to the person, and measures offers objective determination of whether people are getting what is personally important to them. Instead of looking at the quality of how services are being delivered, personal outcome measures look at whether the services and supports are having the desired results or the outcomes that matter to the person, not so much to the provider. These are the results we had with our personal outcome measures. We conducted a personal outcome measure survey, which is basically just a conversation with the individual to get them to kind of tell their story and assess and evaluate how they feel about these particular statements. So you will see the POM statements that we focused on for our measurements for our program. And what you might notice here is that all of them greatly increased from the time we did the original POM statement. The original interview was to determine eligibility. So if a person was already doing really well socially and they were already connected in the community, they already had support networks, they already had a good group of friends, and they felt that they did, as we discovered through the personal outcome measures interview, then we would decide that they were not necessarily in need of the program. So we wanted to focus on those who had the greatest need of these types of supports and services. So with the initial score, that was the introductory rates of what we got for people who enrolled in the program. Then you will see the final score of where things ended after the final POM. So we conducted the POM interview upon enrollment, once midway through, and then again at the end of the program before closing. So you will see the only one that went down was number 17, which says people choose personal goals. Well, our program was all about choosing personal goals. People got to choose their coach, they got to choose their goals, they chose where their meetings were, they chose what they wanted to spend their social stipend on. So we were confused as to why that particular one would go down about choosing personal goals. So we asked our participants, and we said, well, can you help us understand this? And what we found is that according to our participants, setting their own goals in this program made them realize how many other goals were set for them. Once they realized what it looked like and what it felt like to set personal goals, then they could see that the times that they thought it was happening, they thought they were choosing their own goals, they realized that that wasn't the case, and that perhaps they had been coerced into those goals, or they were kind of just subtly set there before them and didn't really understand that they had more choice than what was being given to them. So here you will see a graph here of the changes from the initial score to the final score in our POMs. And the overall result was an increase in quality of life as they described it. We also sent out satisfaction surveys to each of our participants, and the purpose was to provide the participants an avenue to anonymously provide feedback about the program and about the coaches. So we mailed the satisfaction survey to each of our participants and included a business reply envelope with postage paid so that they could return it to us and we could get the feedback that we needed. So it was completed at the midpoint of the program and again at the end of the program. Here are the results of our satisfaction surveys. 17 participants who completed the survey rated the program at 95% with the highest possible rating. So we had 20 participants, 17 returned the surveys. And here you will see the overall satisfaction with the program. Along the way, the coaches took the feedback and were able to adjust and grow to further satisfy and meet the needs of our participants. So it was a great source of feedback for the entire team and an opportunity for the participants to express themselves as well. Another evaluation technique we had was guided journals. In addition to the summary of their week, the journals had probing questions that are intended to get at how their weekly social interactions and the skills they learned are helping them and any other potential issues that they might be having with themselves or with the program or with the skills that they're learning. So from the journal, it could be determined if the program has an effect on someone's overall well-being. The results of our guided journals, the conclusion that we came to was that since people with serious mental health challenges often will not voluntarily involve themselves in a new hobby or a new social situation, the program assists them in going outside of their comfort zone and to become connected with the outside world. In fact, many of our participants even set the goal of wanting to make friends and extend their network beyond the mental health community. Here's a couple of quotes from the journals that we received. One woman says, "It's a wonderful way to get out of isolation and start meeting new friends." Another participant said, "It has helped me to reach out and connect with other people. I love the program. It is like a dream come true. I am learning new things about myself and others." From the journal entries, we also observed that when participants realized that they were more than capable of learning new skills and responding to social stimuli appropriately, they tend to have a boost in their self-confidence. Other quotes that came from the journals, a participant wrote, "The program helps me to be a little more confident. The friendships I have are firmer since starting the program." Another participant said, "The program has taught me that I deserve to be loved." And having been one of the founding life coaches in this program and being able to read some of the comments from the journals of the people in our program, it's quite amazing to watch them grow. I recall one of our participants who really just stayed in the house all the time. She would not go out. She would not leave the house. She had her husband do all of the grocery shopping. The only time she would go outside would be to walk the kids to the bus stop, and then she would come back inside. There was no connection. There was no communication with other people. And this particular woman ended up joining the PTA at her child's school, and now she's regularly involved in school activities with her kids and engaging with some of the other parents at her child's school. So she feels like she can do more as a mother and as an individual, and it was beautiful to see that transition through her journals. Another evaluation technique we used was hospitalization rates. Now, the It's My Life program is, in fact, non-clinical. The only thing we left in the program that was clinical was measurement of the hospitalization rates, just recording that, as well as the diagnosis. And again, the diagnosis was just left in there so that we knew we were helping some of the most challenged individuals socially in our communities. So for the hospitalization rates, we measured the past hospitalizations from 2 years prior to enrollment in the program. We documented them with informed consent from each participant. And any rehospitalizations that happened during their participation was also documented. And then we took note of any other changes in services that the participants received while enrolled in It's My Life. Results were phenomenal. In the 2 years prior to entering the social self-directed care program, together our participants had experienced a total of 15 hospitalizations. In the 19 months of activities, only one member had experienced a hospitalization, one single hospitalization. And aside from joining the It's My Life program, participants had no other changes in the services they were receiving. So we were able to conclude that our program was making a difference for people. It's that social connection, the fact that we need each other. People need people. And it just really is helpful in your recovery to have someone to walk beside you. So today we're going to learn a little bit more about the tools and innovation in the It's My Life program. The major tools incorporated in our program include peer support, self-directed care, psychiatric rehabilitation, and life coaching. So peer support is a broad category of help provided by people who have a problem similar to the one that they are helping. It's mutual support. They have that common ground. So this support includes the sharing of experiential knowledge and skills in social learning, and it plays a valuable role in recovery. Peers encourage and engage other peers in recovery and provide each other with a sense of belonging, supportive relationships, valuing roles, and a sense of community. Now, peer support, a peer support specialist is often referred to as a peer. That's the occupational title for a person who has that personal experience with mental health and or substance use problems, and they're willing to talk about their experience in order to help others trying to recover from the similar problems. Certified peer specialists receive in-depth training on the concepts of recovery and how to utilize their own journey of recovery to assist others. So peer support is an evidence-based practice for the treatment of mental health conditions. Both quantitative and qualitative evidence indicate that peer support does the following: that it lowers the overall cost of mental health services by reducing rehospitalization rates and days spent in inpatient services, and increasing the use of outpatient services. And this can also be seen in the results from the It's My Life program, as we saw the reduction in rehospitalization rates. It also improves the quality of life, which we saw in our personal outcome measures results. Increases patient engagement and self-management, and increases whole health as well. The history of peer support comes from the deinstitutionalization period, when thousands of people that were being held in hospitals and asylums were released into the community. The funds that had been spent on those institutions unfortunately did not follow those individuals into the community. And so communities were therefore unable to provide care for those people, and oftentimes did not want the mental health consumers living in their towns and their cities. The stigma and discrimination was quite prevalent. In the late 70s and early 80s, the idea of peer-provided services and supports was born. The awareness of the violation of civil rights and social justices that were taking place began to accelerate the change. People began talking about the need for peer involvement and empowerment within the mental health system. And that's where we come with the idea of nothing about us without us. Peer support is critical in the It's My Life program because peer-provided services increase the ease of engagement with people, the likelihood that people will fully participate in services, and also increases the amount of time that people stay in services. Also incorporating peer support in It's My Life, peers, they build trust. Now, our life coaches are all peers, and it's about being able to understand because we've been there. It's about saying, I know how that feels, and it's about being the evidence of hope. There's the equality in the relationship that comes from peers. There's the information and experiences that are freely exchanged. And the beautiful part is that both parties benefit from each other's strength and hope. Another innovative tool that was incorporated in It's My Life is the emerging best practice of self-directed care. Self-directed care provides an opportunity for individuals living with a psychiatric condition to assess their own needs, determine how and by whom those needs should be met, and to manage the funds to purchase those services. In self-directed care, the funds follow the person. Unlike what took place in the deinstitutionalization period, when all of those people were released from the hospital, the funds did not travel with them, and so there were no funds to provide the support that they needed now that they were living in the community. Self-directed care programs hinge on the belief that individuals are capable of choosing services and making purchases that will help them begin or remain on the road to recovery and to develop or regain a meaningful, productive activity. The self-directed care movement is a natural outgrowth of the principles of self-determination, which refers to the right of individuals to have full power in their own lives, regardless of presence of illness or disability. That we are people with illnesses. We are people with disabilities. We are not our illnesses. And so we want all of us to be able to have that power over our own lives and over our own recovery. Self-determination also encompasses concepts such as free will, civil rights and human rights, freedom of choice, independence, personal agency, and individual responsibility. The history of self-directed care began with a program called Cash and Counseling Medicaid Program for older adults back in 1996. It was now called the Participant Direction Program, and it's an approach to long-term care personal assistance services in which the government gives people cash allowances to pay for the services and goods that they feel would best meet their personal care needs, and counseling about managing their services. So in 2001, Florida launched an innovative new program for all adults receiving public mental health services known as the Florida Self-Directed Care Program. And that was actually led by Mental Health America's very own Patrick Hendry, who was the program director for the piloting of It's My Life here at our national office. Florida's Self-Directed Care Program allowed individuals to utilize the full amount of funds allocated on a per capita basis for mental health services. Each person determined their own recovery goals, the services and supports they needed to achieve them, and purchased those goods and services at the places of their choice. So self-directed care was one of the most critical parts of the It's My Life program. And that's due in part to the underlying philosophy of self-determination, which, again, in the mental health system refers to an individual's rights to direct their own services and to make the decisions concerning their health and well-being, with help from others if they chose to. Similar to what our life coaches did. We were that person there beside them, giving that guidance as they made their own choices and decisions and discoveries. And it talks about the rights of people to be free from involuntary treatment and to have meaningful roles in the design, delivery, and evaluation of services and support. So everything about this program was self-directed. The ultimate goal of self-directed care programs is to give participants the opportunity to design and travel a personalized recovery, road to recovery, so that they can return to a productive lifestyle as they choose to define it. And people of all levels of recovery can benefit from social self-directed care. It's not just for those who are considered, quote unquote, to be doing well. So through self-directed care, the It's My Life program uniquely provides opportunities for our participants to practice their newly learned skills in a safe and non-judgmental environment and receive feedback from their life coach. The recipients of services have the chance to determine the skills that they feel are important to them. We also provided the financial support to participate in activities they would not otherwise be able to afford. The $60 stipend amount was chosen because $60 was the maximum amount that could be given that would not affect a person's benefits via SSI or SSDI. And our program also uniquely provides creative ways to increase their self-esteem and self-worth, improving overall functioning with networks that include supportive and, most importantly, sustainable relationships that will increase the person's quality of life. So we incorporated self-directed care by having the participants be able to select their own life coach. Once they applied to be in the program and completed their initial personal outcome measures interview, and it was determined that they could benefit greatly from our services, they met with a team of life coaches, all of us that were available, and we'd be able to talk to them and read their bios and to see who had the most peerness for them and who they could connect with and relate to the most. So they got to choose their life coach amongst all those that were available. And then they get to choose and determine their own goals. So they would have the assistance of their life coach to figure out what was important to them, but ultimately what their goals were decided by them. They got to choose which skills were most important to them. And so if they said, I want to be able to work on small talk, that's something I'd like to be able to do when I just go and sit around in a restaurant with people. I want to be able to just kind of have small talk about the weather. I want to talk about just simple, small things and not always focus on illness. And so those were skills that people said they wanted to learn. They wanted to learn how to listen more effectively. They wanted to learn how to communicate more effectively. So those were the skills that they were able to choose that they wanted to obtain. And so each participant established their own person-centered action plan. Once they determined what their goals were and what skills they wanted to learn, they laid out a plan on how they were going to obtain and meet those goals with the support of their life coach. And they were able to create and control their social budget. As long as the things on their budget pertained directly to the goals that they had set for themselves, they would be reviewed and approved by the program director, and they would get the go-ahead to spend the money and move forward with reaching their goals. They were required to keep receipts to document that the spending was done properly, and also to maintain their weekly journals in order to continue to get the monthly stipends. And when it came to meeting with their life coaches, they were able to determine the location for their meeting. They worked with the life coaches worked with the participants as far as scheduling, met with them approximately once an hour 1 hour once a week for skill building, and then spent time with them as the outings took place, and the coach accompanied the individual on the outing until advancing in the program and advancing in their skills, where the coach would gradually draw back and the participant was able to be more independent in their communities. Another innovative tool in the It's My Life program is psychiatric rehabilitation. This is a course that our life coach trainers have studied through Boston University, and psychiatric rehabilitation is a person-centered and strengths-based approach to help individuals with persistent and serious psychiatric disorders to develop the emotional, social, and intellectual skills needed to live, learn, and work in the community with the least amount of professional support, and to increase their capacity to be successful and to be satisfied in the environment of their choice. So there's not just the focus on whether or not they're functional, but also whether or not they're happy, whether or not they're satisfied. That was the key in psychiatric rehabilitation for the measurement of outcomes. Psychiatric rehabilitation emerged in response as well to the deinstitutionalization period, just like peer support, as thousands of people newly released into the community were now in need of a treatment approach that supported and facilitated daily functioning and social interaction. These were not skills that these people needed while they were in the hospital, because they were not living independently, and there was no need to learn about social cues. There was no need to learn about how to properly set a table, which is one of the skills that we taught. There wasn't a need to learn about boundaries and mannerisms. And those were all skills that people identified that they wanted to learn going out into the community. So psychiatric rehabilitation was founded on one of those revelations of that need for people being newly released into the community. And also know that the term psychosocial rehabilitation is sometimes used interchangeably with psychiatric rehabilitation. The expansion of peer roles in psychiatric rehabilitation has at least 5 attributes. We believe that there are probably many, many more. We're going to focus today on 5. One is the deliberate expansion of a peer's role beyond that of a recipient of services, to include helping and support behaviors and activities. 2 is the empowerment of the peer role by recognizing that peers can offer resources that traditional professionals either cannot offer or simply choose not to offer. Sometimes there are boundaries imposed by the organization where a professional, a traditional professional, cannot share their lived experience, cannot share a personal story of how they can relate to the person they're serving. But as peers, we can say, yes, I know I have a similar story, but I am the evidence that it does get better. And to be able to connect on that personal level, I serve as a peer support specialist in other capacities, and I can sit with a person that I'm working with who may be going through a very difficult time, and they're crying and they're upset. And because I'm in the peer role, I can sit and weep with that person, not for that person, but with that person, to comfort them and console them and let them know that I feel what they feel, and to have that sense of connection and empathy. Further expanding the role of peers in psychiatric rehabilitation is number 3, which is the expansion of what is meant by credentials to legitimize the understanding, knowledge, skills, attitudes, and motivations that peers have gained through their encounters with service systems and their experience with mental health as a mental health client. And fourth, we have a view that some kinds of situations and roles, such as outreach, can be best fulfilled or led by providers who are themselves recipients of mental health services. Part of that comes from the rapport and the trust to know that, I can see that this person is exhibiting the skills that they're talking about, and I can see that this person genuinely cares. And that connection seems to be more easily made as peers are involved in these roles of psychiatric rehabilitation. On the number 5, we have a perspective that the provision of help not only assists the user or the recipient of services, but it also creates tangible benefits for the helper, whose identity can be strengthened by helping another person in need. We can become wounded healers. We incorporated psychiatric rehabilitation as it aims to achieve person orientation with a focus on the human being as a whole rather than an illness, and focus on functioning, which is how the person performs in everyday activities, and support, being assistance is provided for as long as it is needed or wanted. An interesting example is we had a few participants in our program who actually withdrew early. Our program, of course, was completely voluntary, and we had people who felt that they met their social goals, they had achieved all that they wanted, they had the friends that they wanted, they had the support system that they wanted, and they felt that they no longer needed the support of their life coach or the program. Another part of the life coaching services is that we help them find resources in the community that they can access either for free or for minimal cost. And so once our participants had developed those skills of being able to find those resources on their own, they began to say, thank you, I've come so far, I see the growth that's been going on here, and I feel like I have what I was looking for when I came into the program. And so they chose to withdraw from the program early, having achieved their goals. And they said their biggest reason for doing that was that they wanted to be able to pass the opportunity on to the next individual that could benefit from it. Psychiatric rehabilitation also aims to achieve environment specificity, basically tailored to the individual's specific environment. That would be where they live, where they learn, where they work, and where they socialize. Also aims to achieve involvement, including individuals as full partners in all aspects of rehabilitation, and of course choice. Focus on the person's preferences throughout the process. We also included the aim of psychiatric rehabilitation to achieve outcome orientation, evaluate rehabilitation in terms of its impact on a person's outcomes, and their growth potential. Focus on improvement in a person's success and personal satisfaction of the person's current difficulties, regardless of their current difficulties. Another innovation that we included in our program was life coaching. The International Coach Federation, ICF, defines coaching as partnering with clients in a thought-provoking and creative process that inspires them to maximize their potential. Coaches honor the client as the expert in his or her life and work and believe every client is creative, resourceful, and whole. Coaching focuses on setting goals, creating outcomes, and managing personal change. You may also notice some overlap here with some of the principles of peer support, that includes self-directed care, as well as shared decision-making, where the person is the expert on themselves. We shared that with our participants as they had difficulties working with some of their providers. And to say that, yes, your doctor may be the expert on medicine or treatment modalities or things of that nature, and they've gone to school and they've studied and they've gotten degrees, and that's fabulous, and we look to them for, wisdom and guidance on certain things. But the individual is the expert on themselves. We have spent our entire lives living in our body and experiencing our experiences. And so nobody knows how we feel but us. And they only know how we feel because we tell them how we feel. And so we are the experts on being who we are. We are the experts on us. So there are, in fact, two experts in the room with shared decision-making. The history of the term life coaching comes from the metaphor referencing the practice of sports coaching. From about the 1830s, a coach was basically known as any form of a tutor. There were voice coaches and tennis coaches and things of that nature. So the term life coaching became a metaphor for this type of profession. According to Merriam and Brockett, professionalization of a discipline is demonstrated by the rise of professional associations, literature, and graduate study. So the emergence of professional coaching associations, training programs, and publications started in the 1990s for life coaching, and it began to be recognized as a distinct profession. Life coaching is incorporated in the It's My Life program as our coaches guide participants to discover their own answers, to help identify challenges and work in partnership to turn them into victories, to challenge the thought behavior patterns, to provide accountability, to empower the participants, or more so to help them find their own power, and to assist with intensive goal setting and action planning. So we concluded that the It's My Life social self-directed care program is highly relevant to any whole health approach to behavioral health. Savings in the reduction of emergency services, increased overall health, and lowered rehospitalization rates makes this an affordable service for managed care and state-funded programs. It's My Life would also be ideal for operation by a peer-run organization and many others. So, as stated, we focus on people with schizophrenia and schizoaffective disorder because we recognize that they were amongst the most isolated and misunderstood in our communities. And that was illustrated by the fact that people with schizophrenia are 6 times more likely to remain unmarried than the general population. So having focused on one of the most marginalized populations and receiving the remarkable results that we did, it's a reasonable expectation, more than reasonable, that greater outcomes would be achieved for individuals with less mental health, with complicated mental health challenges. So anyone, anywhere along the recovery spectrum with any level of mental health challenge or complications can benefit from the It's My Life social self-directed care program. It's My Life is an integrated skill and support strategy, which is designed to help individuals with serious mental health challenge to build networks of friends and intimate relationships, which creates a strong social support system. That helps the participant to become an active member of the community. People need to be more than just residents of the community. They need to actually be involved. And it helps them feel less isolated, which helps increase self-esteem and self-worth, which improves overall social functioning and health. The increase of overall health has shown to decrease the need for hospitalizations as well as avoiding premature death. Traditional approaches such as medication, hospitalization, and dynamic psychotherapy have had limited effectiveness when applied to socialization and work aspects of individuals with psychiatric disabilities. So it's important that It's My Life provides one-on-one skill support and help to build those skills of connecting with people and being able to work and being able to socialize and being able to network and connect with people and even to grow personally and professionally if that's a person's choice. So one-on-one skill support emphasizes that self-direction is, again, not just for those who are doing well. Mental Health America's vision for the future of social self-directed care as a part of recovery, our goal for the future is to see It's My Life implemented across the country, across the world. The program effectively addresses the need that each of us has to build friendships and connections to our community. And self-direction empowers us to take control of our destinies. If we can learn to set goals and action plans and carry those things out and attain the goals that we set for ourselves in this area, we can take that and apply it to so many other areas of our lives. And we have seen our participants do that even after the program had ended. Social inclusion is about being able to participate and contribute to social life in economic, social, sociological, psychological, and political terms. To do this requires having personal capacity as well as access to a range of social roles. The It's My Life program is suitable to be operated by peer-run organizations, state mental health establishments, community services boards or mental health centers, church or other faith organizations, Mental Health America affiliates, NAMI groups, and many other organizations could implement this program. So in order to get started with implementing It's My Life, you would need fidelity to all of the basic principles of the It's My Life model, especially remaining truly self-directed. That is one of the core pieces of the It's My Life program, and it simply doesn't work if it's not self-directed. Attending Mental Health America's 3-part training webinar. Today is part 2. If you missed part 1, we will be placing that recording and slides on our website, just like we will be doing for today. And you will also need community resources to get started, and that really refers to being aware of what's available in your community for people to get engaged in socially. Also, to get started, you would need the It's My Life training manual, participant handbook, and the various handouts that we use throughout the program. Majority of these items are available currently on our website for free download. We will be adding more soon. Those who engage in It's My Life's training that we are now offering will receive a training kit with all of these materials. You would also need a peer support specialist to serve as your life coaches, a program director to oversee the program. This individual may or may not be a peer. And, of course, funding. Possible sources could include state mental health authorities, CSBs, the community services boards, mental health centers, philanthropic organizations, individual donations, or other fundraising ideas that we also offer during the training that MHA provides. Our pilot program was funded by Mental Health America and a grant from Janssen Pharmaceutical Companies. The funds for the program go towards salaries for the program staff, unless you have volunteers, training of the coaches. The training that we provide is free if it's done virtually. There is a cost if you would like us to come out and do the training in person. Funds are also used for program materials. That would be the binders, the printing, any other materials that you would need for operating. The social budget for participants, and reimbursing the coaches for travel and outings with the participants. And, of course, that would vary from agency to agency depending on your policies. So Mental Health America's experienced peer life coaches are available for individual or group training in person, by phone or video. So again, the training that Mental Health America now offers, virtual trainings, are conducted through our webinar software, and they are free. In-person training is also available for a reasonable fee, and that mostly covers the travel expenses of our training team. The training that Mental Health America provides and identifies the key parts of peer support, shared decision-making, information from the Center for Psychiatric Rehabilitation from Boston University, study that we did on life coaching, and motivational interviewing. So we have taken the most critical parts from all of these resources and compacted them into training sessions so that your life coaches will be able to get the most important parts and not have to go through the entire study that our coaches did, and be able to compact it down and concentrate on the most important parts. So our training includes flexible scheduling to meet the needs of your team, the training kit, as well as individual instruction sessions for the program director, and that would be separate from the sessions for the life coaches. Of course, the program director hopefully would sit in on that training as well. And Mental Health America will provide technical assistance even after you have implemented the program to help ensure successful implementation. Also, MHA is introducing It's My Life Social Explorations, the support group format. This is brand new. It will allow organizations to reduce their expenses in implementing the program by using a support group format rather than the individual one-on-one services of our pilot program. Training for this format will also include additional resources relating to support groups. Mental Health America would like to thank Janssen and Alchemies, who were our sponsors, to help us train other organizations to end social exclusion and isolation through the It's My Life Social Self-Directed Care Program. So thank you for joining us today. This concludes part 2 of the Defeating Isolation and Social Exclusion Through Peer Empowerment webinar. Part 3 of this series will take place at 2 p.m. Eastern, and that's 11 a.m. Pacific time, on December 19th. Announcements will be going out for that shortly so that you will be able to register. Again, that will be December 19th at the same time. If you have any additional questions, please feel free to contact me here at Mental Health America. My telephone number is 703-946-0529. I can be reached by email at scarpenter at mentalhealthamerica.net. We will be providing certificates of participation for those of you who would like one. Please note that these are not continuing education units. These are not CEUs. They are continuing education hours, which often are a benefit to peer support specialists who have to do similar ongoing training. So if you are interested in a certificate of that nature, please do send me an email. I am aware that many of you have not yet received your certificates for Part 1, but I assure you that they are coming, and you will also be receiving a certificate for Part 2 if you participated today. I would just simply need an email requesting that from you. I will get back to everyone with your certificates, and also these recording and slides will be available on our website in just a couple of weeks here. Look forward to the next Part 3 of our webinar. Again, if you would like a certificate, please do email me. If you are interested in implementing the It's My Life program and would like to set up some training or just a conference call or discussion about how you can move forward with this amazing program, please do contact me. Again, my number is 703-946-0529. Email address is scarpenter@mentalhealthamerica.net. That's SCARPENTER@mentalhealthamerica.net. Again, thank you, everyone. We do apologize for the technical difficulties at the beginning with audio, and we will see you back at the next webinar. Don't miss the Empowering Experience Part 3. I have just been notified that there were still some questions and answers coming in. So if anyone's still online and you've got some questions, I apologize. I missed that part. If you have any questions, please do go ahead and type them into the question and answer session. I did not see very many come through other than the audio concerns. But if you have any questions, please do enter them now into the question and answer session, and I will get to those questions at this time. Okay, so it looks like we don't have any other questions. Again, I am available if you think of anything after today's webinar. Please do contact me, and I will be happy to answer any questions that you will have. Thank you. Thank you very much for joining us, and we'll see you next time.